Life is based on probabilities, but we often don't think about it in terms of a numerical scale. And in this video, we're going to examine probabilities and how thinking about it on a numerical scale can help us make more informed clinical decisions. Probabilities are present in everyday life, and sometimes anecdotally we'll say things like, yeah, it's 100%, no, definitely not. But the unfortunate thing about probabilities is we can never actually rule anything completely in, and we can never rule anything out, that we can never be completely sure or completely confident that something is either there or not. When we're consulting with a patient, in our minds we're often thinking of the probability of a disease process being there based on the signs and symptoms, but we don't often relate this to a number. When thinking about probabilities in terms of thinking, we're moving away from the System 1 intuitive mode to a System 2 critical mode, where we're having to weigh up the evidence in terms of how probable is a disease process in being there. Probability, in terms of numbers, we can represent as a number between 0 and 1. The more certain we are that a disease process or a phenomenon exists, the closer to 1 we'll be. Conversely, the less certain that we are that it will not exist or a disease process is not there, we'll be closer to 0. The problem is that certainty in life and clinical practice, as I'm sure you're aware, is quite rare. Before we move on, there's some key terms that we need to understand. And the first one is the prior probability, sometimes referred to as the pre-test probability. And this is your representation or your probability of a disease process being present. And this is a number or a likelihood that you'll attach in your head during your differential diagnosis. And this is the reason that we're asked to order our differential diagnosis in terms of the highest probability first. And this is based on the information that we've gathered during our consultation with the patient. So the more information that we can gather, the more that we can relate it to those signs and symptoms, the more confident we are that the disease process is there, and therefore the more likely the probability. The other key term that we need to be aware of is after we've done the test, and this is the posterior or the post-test probability. And this is influenced directly by how confident we are in terms of our pre-test probability. The take-home message from this session is that the more sure you are of a diagnosis, the more probable it is in your own mind that it's there, the higher it will be with a test. Equally, if your pre-test probability is quite high of a diagnosis or a disease process being there, and you get a negative test, it doesn't exclude the diagnosis. You may need to move on to do another test. Although this graph looks quite complicated, it's actually quite easy to understand. And on the bottom axis, we have the prior probability or pre-test probability that we as the clinician would attach to a diagnosis after taking a history and examination of the patient. On this axis here, we have the posterior probability or the pre-test probability. And this would be the probability of the disease process being present after the test has been done that is appropriate to diagnose that disease pathology. We also have two curves on this graph. The first is the positive test curve, and the second is the negative test curve. And depending if the test is positive or negative, we have a positive and negative shift in the probability. So for example, let's take a patient who we see who has a 30-year pack history. He's got a barrel chest, he's out of breath, he's tired, he's lethargic. On auscultation, he has a clear chest with an expiratory wheeze. We could probably reasonably confidently say that this sounds like it could potentially be either COPD or asthma, and we might attach a probability in our mind that we're 75% sure that this gentleman has COPD. The next logical thing to do is trying to do a test to increase the probability that we are correct. So for example, if we were to carry out spirometry on this gentleman, we would then transverse up and meet where the positive test curve is. And what we can see here is that we have actually increased our probability to somewhere around 90% that this disease process is present. Conversely, what could happen is that we could be 75% sure that this gentleman has COPD and send him for spirometry. But what happens then if the test comes back as negative? If we go up the curve to the negative test, we would have a negative shift in our probability and it would go to 25%. So then we need to ask ourselves the question that our clinical suspicion was high that this gentleman had COPD, but unfortunately our test came back negative. And what we could potentially be dealing with here is a false negative test, in that our clinical probability of this was high, but then the test was negative. However, we still have a 25% chance that this gentleman could have COPD. A similar case actually happened to me in clinical practice, and this got me quite interested in attaching probabilities and this method of reasoning. I saw a patient who was 3 days post-operative, and when I came onto the ward, he was breathless with low saturations of around 86%. He was quite tachypneic, and doing a blood gas, he was in type 1 respiratory failure with a low PO2. Automatically, after having hip surgery, I surmised that this gentleman might either have a PE or an infection. I went on to do a chest x-ray to exclude any infection, consolidation or collapse, which came back as negative, and so my probability of a PE was reasonably high, and I estimated this was probably about a 70-75% chance that this was a PE, and therefore continued on with the CTPA. When I got the report of the CTPA, I was actually really surprised to find that this gentleman apparently didn't have a PE. This gentleman was then given antibiotics because he had a high white cell count, thinking that it could potentially be an early infection, although the elevated white cell count could have actually been because he was post-surgery, and he was taken to theatre. Unfortunately, he deteriorated on the way down to theatre and was brought straight back up, and while we were dealing with the critically ill patient, we actually got a call from a consultant radiologist who said that the CTPA that was reported as negative was actually positive, and it was human error on the side of the registrar that was reporting. So if we relate this directly to here, we can see that I was probably 75% or 80% sure that this was a PE. But if we go up the negative curve and across, we can see that it's still around a 45% chance that this PE was actually present. And what I had there was I actually had a false negative test, in that the disease process was there, but the test was not sensitive enough in terms of reporting to actually pick up that this gentleman had a PE. Reflecting, if I'd have used this form of clinical reasoning in practice, I would have been inclined to actually ring up and say that clinically this gentleman is presenting like a PE, and I'm not confident that the report has been scrutinised enough, and I probably would have rang the consultant earlier. However, I was in the second year of my training and not quite confident to make these decisions yet. You could probably argue that my illness scripts weren't quite complete, and I'd never experienced this before, and assumed that reports are always correct. And obviously that's a wrong assumption, and a cognitive bias that I then had to deal with later on in my training. And you can see how this relates to probabilities as well, that what I should have recognised is that my clinical suspicion was high, we had a negative test when the clinical signs were all pointing to a P, and I should have raised the question that this could still be a P, and we may need to either repeat the test, or we may need to get a second opinion on the results of the scan.